Hello, everyone. Welcome to Tuesday Night Rheumatology. Tonight, we're going to be discussing early RA. I'm Jack Cush with Rheum Now. I'm joined by good friends and experts in the field, people who've been working on and seeing patients like you and I with early RA. I'm going to ask our other panelists to introduce themselves. Marty?
Good day. I'm Dr. Martin Bergman. I'm a clinical professor of medicine at Drexel University College of Medicine in Philadelphia, private practice, and a master of the American College of Rheumatology.
Excellent. Glenn?
Glenn Hazelwood, rheumatologist and associate professor of medicine in Calgary, Canada.
And I believe we're going to be joined shortly by Vivian Bykerk, who's trying to log on as we speak. I'm Jack Cush in Dallas, Texas. Tonight, we're going to be discussing RA, and specifically early RA. As you may have noticed this month, we have a campaign all month that's featuring a lot of content around the topic of RA. It's called Hard Decisions in RA. We've got a lot of videos and blogs and vlogs and whatnot. And we hope that you can enjoy that content.
Can you hear me?
Yep, we got you, Vivian. How are you?
No.
Yeah. Can you hear us, Viv?
She may be on mute on her speakers.
Yeah, I can. We can hear you and we can see you.
Now it will work.
Okay.
We're
Hi.
good.
You got us?
I gotcha.
Okay.
Hello.
Vivian, we just did introductions. Why don't you introduce yourself?
Okay, well, I won't know who you are, but I'm Vivian Bykerk. I mean, I know who most of you are, obviously. I'm Vivian Bykerk, and I'm a rheumatologist, clinical researcher who is very interested in early RA and best outcomes for early RA. I work at HSS, but I'm a Canadian, and my heart is still in Canada.
Excellent.
Actually, no, part of my heart is in Canada.
You can be bi-coastal or across the border, and
I can be by 42nd parallel.
there you go. Excellent. All right. So what I want to do is get into the subject where we're going to discuss referrals in RA and treatment approaches, and then also touch on where we stand with regard to preclinical RA and the current approach. So with that said, I'm going to get right into a survey that we did of the rheumatology readership yesterday. And with but one day of survey results, we came back with these findings, these results. We had 211 responses from 43 countries, half of which came from the United States. We asked a total of 5 different questions on, again, referral and treatment of early RA. The first question at the top left: how many early RA patients with symptoms of less than 12 weeks do you see? And half see 1 or 2 a month. A third see hardly any. There's a few who see about 1 per week or more. And then many by 7%. So 20% of the people who responded to this said they see actually quite a bit, which is surprising. I'm now going to bring in on the bottom half of the screen the US results. And it's really the same, maybe a little bit less of US people. This looks like about 13% are seeing a lot of early RA, but most people, it's about 80%, like it is worldwide, really see but a few patients. I don't think that that's surprising, because that's answered in the second question. On top in the middle, do you have an early RA clinic or a facilitated plan for early RA referrals? And 57% worldwide said no. In the United States, 59%. Yes is the answer. It's somewhere between 14 and 26%. And then this is the delusionary answer, meaning I just say it's okay for the PCPs to call me, which means that ain't really happening. I agree that you'll do that. But by the way, you've also never sent a letter to any PCP saying, call me when you have an early RA patient. So it's sort of a fallacy that, again, the problem is most of us want to live in a situation where our clinics are full. The third question, and then we'll get into a panelist response to these questions, if you suspect RA based on swollen joints in a new patient, what serologies do you do? And amazingly, doesn't matter where you live worldwide, everybody does a full serologic panel. Really? I guess you're not paying for that, because why would you do an ANA in someone in whom you suspect RA? I don't know. Some people do, and they can dance around that issue all they want, but that's wasteful. And that's currently sort of against ACR recommendations. 40% say I do an RF and CCP. And then there's a few people who do just CCP or RA. My take on this is that there's a lot of, shoot from the hip, easy algorithm approach to early RA if I see them. But then again, I'm not seeing them. Marty, what do you think about this?
Well, first of all, I think the responses are honest in that I think this is what people are more or less seeing and more or less are doing. So I think that I don't think people were sort of puffing and saying, oh, I see 15 people new RA every week and they're all doing well. And I mean, we'll get into the facilitating clinics and the like in a little bit, I'm sure. When you talk about the serology, I'm going to give people a little bit of a pass just because of the way the question is worded. You suspect RA, but they have swollen joints. So there are situations, I mean, if they're puffy joints, you could think it's systemic sclerosis, you could think it's lupus. So I'll give them a buy on that. I understand your point. If I think they have RA, and I'm not getting I always refer to this as the Casablanca approach, arrest all the usual suspects. And so I think that's what's done. But like I said, I'll give them a little bit of a pass because of the way the question was written.
Can I ask all the panelists, do any of you have an early RA clinic?
Yep.
Yeah, we do.
The damn Canadians, they're way ahead of us, Marty.
But I'm in America.
Well, again, a lot of this has to do with the type of practice you have. I was a solo practitioner. So having an early RA, trying to block off time with RA when my wait list is 3 months, it gets to be hard. I would be in the PCP just needs to call group, recognizing two things. One, they're not going to call. And two, when they do call, almost always it's fibromyalgia. So, I mean, that's the only time I really got phone calls was, I just want this person out of my office. They're bothering me. Who can I dump this on? And it was coming and it was a fibro. If I had gotten early RA, I would have been absolutely ecstatic.
So,
Glenn, do any of these results? Go ahead, Vivian. Go
I
first.
mean, if you think from the PCP's perspective, the incidence of early RA is what, 1 in 1,000 per year. So maybe they're seeing 5 a year. So you're not on their speed dial, unfortunately. And you're lucky if you remembered why you refer. And regarding the serology, I'm with Marty on that, especially in an environment where you don't want to miss things. And they do have signs after all. And I have seen, yes, fibro in an early RA clinic, but I've also seen some lupuses. So I'd want that. And I agree with that. I don't agree in doing only RF or CCP early because there still is a 30% disparity. I think you need to do both. I think that's money well spent, and it's also for billing purposes important. But I think these people that are seeing lots of it are in catchment areas where there are very few rheumatologists.
Glenn, do you do it differently?
Well, the one thing I'm noticing here is it's uncommon for me to see a patient with less than 12 weeks of symptoms, to be honest. And the people I do see are typically have really high disease severity, sort of the preclinical RA patients. By the time they kind of filter through the family doctor and get referred, most of them, I would say, are beyond the 3-month window. And then we typically, just because we do have a big manpower issue, actually request, and you can, argue the merits of this, but request that GPs do serology before with the referral, because it really does help us triage the referrals. So most of the people I see have RF, CCP, and ANA done.
Yeah.
And that's really because the referral information is often hard to rely on, and it helps us flag those patients that really do need to be seen more quickly.
So this,
yeah,
Go ahead, Vivian.
I agree with that, but 30% of our patients are seronegative, and the only way they get to us is having a lot of active disease. So we've shown that if you have super active disease and seronegative, you're more likely to get into at least our early RA study. And fortunately, people who present that way tend to do better for some reason. It doesn't harm long-term outcomes.
I mean, I was going to say the same thing as Dr. Bykerk has said. It's serologies are great when they're positive. Like I said, 25% are seronegative. Rheumatoid factors and CRPs are normal at the time of diagnosis in 45% of the cases. I mean, that's Ted Pincus has done that study with Dulika Soka. So just relying on serologies is a problem. Seeing people within 12 weeks. The fact of the matter is, I'm not even going to blame the PCP on that. You wake up in the morning, your hands are kind of stiff. Oh, I was achy. Oh, I raked too much. I drove too hard. I walked too far. I'm going to take an NSAID. Oh, well, and then you just keep on filling in the blank with what it was. It's probably 12 weeks before they see the PCP.
That is correct.
Yeah.
So
Well, and the other thing is it often starts, and we've shown this in Canada, as sort of an intermittent palindromic. Like if you ask people when they are diagnosed with RA, when their symptoms started, it can be hard to define, and they often have these sort of stuttering course of palindromic symptoms prior to progressing into sort of full-blown RA.
So there is certainly the patient delay in seeking help, and it doesn't even begin with you. And then there's the PCP delay. I must say, I was doing a recent search on Twitter for a number of different things. I just put in the search word rheumatology. It's gigantic, the amount of rheumatology bashing that's out there in the world, with the message being, I can't get in to see a rheumatologist. Meaning my primary care can't get me in. It's a 3 months, it's a 6 month, it's a 9 year. I mean, it's pretty sad. And that goes to the first question in the upper left here that Glenn started with. What's the average symptom delay on patients that you see, with most patients being 3 to 6 months? 6 to 12 months is 40% worldwide and 32% in the US. It's very uncommon for people to have less than 5 weeks. It's like a sliver, 3% or less.
That's when you know someone.
Probably, exactly.
Yeah.
And I'm going to say that 3 to 6 months is still probably even optimistic.
Yeah.
From symptom onset.
I think you're right. I think you're right. I can tell you that when I was in practice and looking for to start an early RA clinic, and 2, looking for early RA patients for clinical trials and making efforts in this regard, the simple thing that I did is I had a pad, like this size pad, that I printed out that had the patient's name on the top, a little bit of demographics, the reason for referral. Send us your early RA patient and check a box. And it said, and they had to just check a box: swollen joints, abnormal labs, whatever. It gave them 12 choices. In the bottom, it said, fax this page and the patient's notes and labs. You'd be shocked at how effective that was. Meaning, yes, unbelievable. Number 1, I got way more consults than I ever did. Number 2, all the consults I had came with full labs being done and even x-rays, and they were in the consult, as opposed to, oh, I'm referred here because my doctor has said I have an abnormal lab. Which one? I don't know. Where's the result? I don't know. And this really, really worked. But it goes to the point of, I can't blame anyone else if I didn't do my job, which is give people the tools to appropriately refer. And if you really want these patients, every rheumatologist I know is a strong believer in early diagnosis, early intervention. We would love to be able to do that, but we don't get the opportunity. That's the problem.
Now we have Epic and we have care everywhere, and we can see, in many, many cases, we can see everything that's been done for years. And what tests have been done. I think it's still that it's recognition by the patient that their jogging did not cause their finger to swell, and B, the delay to get to a primary care should they need the referral. Now, fortunately, this is being less and less of a requirement. Then the patient has to figure out what a rheumatologist is and figure out how to get to us, and they may or may not speak to a PCP if they have one. So, you know, there are new barriers.
You know, I do a lecture I started last year. I'm trying to continually refine it on the future of RA, which has a lot about generative AI in it. And this is where you have more efficient identification of people, with very rare diseases, you know, like the Milwaukee shoulder syndrome, never seen one of those, or early manifestations of common diseases, which in the primary care sector still are rare, like RA. And that's where in a system, this is going to be very, very efficient and make it better for patients and for the practitioners. And it's not that far away. It's like within the next 10 years, and largely in bigger hospital systems like Epic, as Vivian was saying.
And I also think, though, this is a role, I mean, realistically, a role where we should be doing more education of the MP and PA community. Because whether we want to admit it or not, patient comes to a PCP, at least in my community, they go to a PCP with joint complaints, they're not seeing the doctor. They're seeing the other adjunctive, the other people. They're not seeing the physician, they're seeing the others. And as a result, if they're not trained to recognize RA, it's never going to be recognized until they're basically, you know, wheelchair bound, and then they're passed over to the PCP who says, I got to get this out to a rheumatologist.
So I think, yes, better education, better referral rules. I mean, Paul Emery has been touting the same referral rules for years, which is a positive squeeze test, arthralgias, and an abnormal test. You know, you should be referred. I want to ask this question from Gail Kerr. It's a good one, and it's a common one. Most referrals are for arthralgias and low positive RFs. What percentage of those people end up having RA? Does anyone have a good number on that?
I just answered that. I wasn't sure if we were going to take them verbally, but you know, it's the proverbial, it depends. So if the low positive is 10 points above normal, even 5 points above normal, and their arthralgias are in their MCPs and wrists and MTPs, that's pretty high. Distribution's right, it's not normal. You know, I would take that one pretty seriously. If it's back pain and you know, your upper limit is 8 and it's a 9, that's pretty low.
But when she makes it polyarthralgias and low titer, it's still on the low side. When it gets to be high titer, double positive, then it really takes a big jump, right, in yield.
But in the criteria, yes.
Well, also in APIPRA looked at that, and that's where they found that it was really those high titer high titer double positives were the ones who had, and they had the arthralgias. They also had evidence of synovitis, which means they had RA. But they were the ones who are most likely to respond to early abatacept.
Right, and that they are more likely to have the shared epitope.
Right. But again, you're now starting to say, you know, if you have somebody who's strongly dual positive, has pain and tenderness over their joints and an MRI change in their MCPs, for me, why are you doing that early preclinical? That's just RA.
You know, I think the bigger problem is what people are calling pre-RA is really already RA. Once you have erosions, you have RA.
Done.
Especially in the setting of CCP or RF, and especially in the over 250 crowd, meaning the titers are super high.
Well, the criteria make you believe it's a dichotomous, score-based, crossing the threshold, and in fact, it's not. As we're all agreeing here, it's a succession of events, and the more you add into the story, the more the diagnosis likelihood ratchets up, and we're all going to have maybe different thresholds for when we're going to write that DMARD. Let's get into this question about therapy in early RA. This is the next question here. which of the following do you rely on to diagnose, to diagnose, no, we're going back to the beginning. Sorry, I know, actually, I went ahead. So I missed this question here. Second question on the upper right. What's your preferred first DMARD in newly diagnosed seropositive RA, 2 swollen joints for 3 months? What's your preferred therapy? Doesn't seem like it matters whether you're in Canada or South America or the United States.
We finally got the message across.
90% are using methotrexate. A sliver are using 7% are using hydroxychloroquine, 1% are using a biologic or a JAK. While this is probably encouraging, I mean, I learned from Fred Wolf, rest in peace. Fred Wolf passed away a week ago. Use your best DMARD first. So the idea of using your weakest DMARD, your safest DMARD, some DMARD that spells easier, why not use your best DMARD first? And that is the answer here. I'm a little concerned that we're all treating the same disease, which is not the same disease, the same way.
Well, it's where you start. And where do you start? Well, you're going to start one where, frankly, what's on my formulary? I mean, there is this myth that physicians choose. They don't. We go to formulary. 2 is methotrexate is an effective drug. I mean, you can get people into a low disease state / remission 25% of the time. And, they've shown a clinical trial. I have data from my own practice. I can do it about 25% of the time with an inexpensive drug, has a long history. We know how it works. We know its toxicities. We know how to monitor it. So why wouldn't we start with the most effective DMARD that we have before we go on to the others that, well, you can't get anyway until you failed methotrexate?
I honestly think we need to rename methotrexate to awesome drug. If we renamed it, and you were telling your patient you were going to go on awesome drug, what do you think their anticipatory anxiety might be? I guess that's a double similar word, but you're much less likely if you look up methotrexate. It's tarnished. It's still
It's a cancer drug, first of all.
It's scary.
It's scary, absolutely.
I would almost view this as, I know this is percentage of respondents, but if I think of 100 people with this presentation, maybe 90% I would start on methotrexate, but there is a proportion who just aren't going to take methotrexate, and you can try to convince them. I don't know, I find it's around 10%, where hydroxychloroquine might be something that they will take. And so I thought that was interesting.
Well, here's the paradox is that we were part of the Stop RA trial, randomized control study trial in pre-RA of hydroxychloroquine versus placebo. And of course, the consent said you may go blind from this medication. Do you think I could get a single patient on that into that trial? No. On the other hand, if I said you're going to go on awesome drug, and if you lose hair, we'll boost your nutrition and it'll probably just come back, they're probably going to take awesome drug.
Yeah,
I agree.
Is there a scenario where any of you
hydroxychloroquine? I'm sorry, Jack, but with hydroxychloroquine, yeah, that's okay if I really don't think they have RA. If someone has, somebody is there, they've seen me, they have 2 swollen MCPs, they're clearly in discomfort. I use the rapid 3, but they show that they're doing poorly, and I think it's an inflammatory disease. I'm hard pressed to say, oh, let's give you hydroxychloroquine, unless I really just don't think you have anything.
It's
Oh,
I think, yeah.
Let me ask this: is there a scenario where, first off, for the audience, we would love for you to join the discussion and give us and put your questions in here that we can further discuss. Put your questions in the Q&A box. That would be ideal, like Dr. Kerr did. But I want to ask the panelists: is there a scenario where you would use more aggressive therapy than methotrexate, either a JAK or a combination or biologic in someone who's presenting to you with early RA?
We couldn't use biologic or JAK inhibitor. That would be just out of funding, but for sure combination therapy, and really based on disease activity.
And is that the game you play so that you can get to biologics quicker? You put them on triple DMARD, and so that maybe you might be able to use a TNF inhibitor at week 12?
I know a lot of people do, but I actually think there's a role for it, even if you're not, even if that's not the intention. And I'll use triple therapy with the sort of discussion with patients. Once you're in remission, we can always back off on the medications. And if you sell it to people that way, that this is kind of, I know we're giving you a lot of treatment. The goal is to get you into remission as fast as possible. And then once you are, we can start backing off on things. I find people buy into it a lot more, and actually a lot of people prefer that over starting with methotrexate. If it doesn't work, we have to add in things, it's delaying things, etc. So
we're making a lot of assumptions here. The adherence research, says people used to throw their paper prescriptions in the trash going out the doctor's door. We don't know how much they're actually trying or doing or say they will. And I think the real key is, and to Glenn's point or Dr. Hazelwood's point, is that we're starting these meds. You need to see people often in the first few months, even if it's a quick check-in, because they need to tell you what their worries are, and you need to ask, what are they doing? Or what are you experiencing?
So let me weigh in on this. Dr. Bykerk is referring to a well-done, very large consumer report study that says people who go to their doctor for an antibiotic, when given an antibiotic, less than 50% fill the prescription. And we certainly have a lot of non-adherence data, especially in lupus, but even in RA. But the question is, do they really? I think in my own experience, I think that, Vivian, your solution is perfect. Bring them back, see them more quickly, and reinforce the need for the therapy. But if I bring them back in 3 months, half the patients are not doing well. And I think a significant amount of that is they're not doing what I told them to do.
I know.
And I will just put in a plug for disease activity measurement. And I don't care which one you choose,
Right.
I did the rapid 3, so I have my love for it, but I don't care which one you use. But if I give you prescription and you decide not to take it, and then I bring you back in 6 weeks and you're doing great, well, more power to you. You were right. You didn't need the medicine.
Right.
On the other hand, if you come back 6 weeks and you're doing horribly, you look, wow, you're doing horribly. What's up? Are you taking the methotrexate? Are you having trouble with it? What's the story? So for me, I think disease activity measurement is also a way that we can get a handle on, are our patients taking it or not?
So Dr. Kerr asked the question about what's the documentation for a 2 or combination DMARD approach. And it could be Finreco, it could be a Cobra, Best. There are a number of studies that show that it is appropriate. I don't think that those studies were segmented out into, high risk, low risk patients and that kind of profiling. But if you look at the patients that went in those studies, they were all high risk. They all had, 30 tender joints, 14, 15 swollen joints, high, really abnormal labs. They were a mess. So it would have been appropriate for them to get combination, a more aggressive therapy than single drug, God forbid, even placebo. I think there's plenty of evidence to support that. Anybody like to look at any one data set in guiding them in this situation?
I mean, I'm blocking on the study, but it was the head-to-head methotrexate etanercept versus triple therapy.
Yeah, there's a tier in the RACAT trial.
Yeah, the RACAT, that was the one. And I have issues with the methodology, but if you're looking at something that you could show a reviewer, triple therapy right off the bat did just as well from those 2 studies.
Well, yes and yeah, yes.
I mean, I'm saying if you want to show it to a reviewer, I have issues with the studies, how they're done. I mean, we can get into that, but when you're, the question was,
No,
How-
you
what's
could
my
say
documentation?
if you want to get 50% better, they're the same.
Right.
Okay.
And quicker too, like the main
That was the
advantage
advantage, right.
was, yeah, it happened quicker
there
compared to
were-
starting with methotrexate and then escalating to triple therapy.
But the ACR 70s were better for etanercept methotrexate, as was the reduction in radiographic progression, which just says there are a group of people that probably need a TNF inhibitor. There are others who will do well with a combination.
And there are the others who will do fine on methotrexate monotherapy.
Exactly.
Yeah.
So Kelly Portnoff basically goes down this path by saying that he would consider a biologic as first-line therapy in women of reproductive age who are not taking reliable contraception or entertaining pregnancy in the next few months, that a biologic may be the better of all the choices. One, for faster onset, and two, maybe a known safety profile. And any oral meds you might take really might have a long drawn out effect where you have to close the gap with steroids, and that may not be the ideal situation for anyone early on.
That's a whole nother issue. The thing is, in those contemplating pregnancy, or we'll call it, have a high probability or a decent probability of pregnancy, if they have one PIP joint, I might give hydroxychloroquine and I do a pretty good exam. But if they have 3 or 4 joints, I agree with that.
And that's the one where I've had good luck with it. You don't do it a lot. If you don't do it all the time, you're actually more effective. And that's where you actually call the medical director and say, hi, this is what's going on with this patient. And this may sound, for those people who know me, this may sound a little bit weird, but they're actually, when you get them one-on-one on a phone, they're actually pretty reasonable people.
Well, that's arguable. So I couldn't help that. Nothing's been said here about steroids. Early RA patients who present get tons of steroids in the primary care sector, and yes, in rheumatology audiences. I'm a disciple of Paul Emery, says, early disease shows up, might be RA, not yet RA. It's a high dose intramuscular steroid along with, a tapered dose, and let's see what comes back, since half of them are going to go into remission. Do none of you have a substantial role for steroids in early management, Glenn?
Yeah.
I'll do it in the less than 12 weeks, especially the really early where you're not sure if it's just, the less than 6 weeks sort of person that shows up in Emerge. That's kind of a situation where I'll do it because it could be could be whatever, right? It could be a viral induced arthritis, etc. But in somebody who's usually in my clinic, who has, as we mentioned, symptom duration longer than that, I'm really hesitant to just give steroids without a DMARD, because I think a lot of things get better with steroids other than inflammatory arthritis. And we use it all the time. We use sort of IM pretty frequently when we're starting DMARDs, but I'm very, very hesitant to do it without starting a DMARD at the same time. Because I think patients love it, and then they come back and want more, and then
they won't take methotrexate. They
yeah.
might have taken awesome drug, but they won't take methotrexate.
Yes, exactly.
And the other thing that I've been doing, I learned this from Ted Pincus years ago, which is I don't use 10 and 20 milligrams of prednisone. I use 2.5 milligrams of prednisone. If I really want to pound somebody, I'll give them 5. And number one, I'm finding it just as effective. And number 2 is you don't get this, I want that drug because I don't get that, woohoo, I feel great.
Right. Well, this is crossing over into this issue of what to do with preclinical RA, but let me show you the results of a preclinical RA survey we did 2 or 3 months ago on Room Now. This was done in June, late June, after EULAR, 246 responses. How many new, again, remember, I think it was like 2/3 of people saw very few early RA as defined, right? And here we're asking how many new polyarthralgias preclinical RA patients do you see in a month? And it's 57% see 1 to 4, 24% see 5 or more. What? I mean, these numbers are
I don't know where this is coming
preclinical. I don't
from.
know who these people are. In the United States, it's the same. So it's not like these are, those crazy people who live in Canada. This is that pretty much everybody does this. But which may I guess this is a lot of consultation, referrals for arthralgias, and maybe that's what people are considering here.
The
That's
problem
how I'm
with early-
interpreting it. Go ahead, Vivian.
The problem with preclinical / early, transition to early RA is that there's a lot of tendon disease. And I'm not sure people appreciate that.
Mhm.
So I can see that, that RA may be called preclinical because there's less articular and more tendon. So if you get extensor carpi ulnaris tenosynovitis in pre-RA or early RA, that's like pathognomonic of RA almost. People don't think about that.
I mean, I'm going back to what I said with the phone calls, because this is where I would classify those patients. This is a person, I'm getting the phone call for polyarthralgia. My patient has lots of aches and pains, please see. Now, how many of those actually have an inflammatory process? That's a different story. So if you're asking the question, how many new people with lots of aches and pains are you seeing per month? It is going to be a lot. How many of those actually have what I would consider to be, quote, preclinical RA, unquote? It's probably 1 in 100.
Yeah, I probably would have changed this or had this colored significantly if I threw in a CCP positivity, into this equation.
Yeah.
So, but let's see what happens when you ask the question, what do you need to diagnose preclinical RA? And there's a strong reliance on seropositivity, both worldwide and in the US, lesser requirement for the number of joints, and nobody else really looks at anything else. So that's
So Jack, did you write it was this the way? Because I see number of tender joints, and I don't really care about tender joints. For me, it's
Right.
the number of swollen joints.
well, it's
That's far
but
more
no.
important.
This is the person. Well, yes, for rheumatologists, it would be the number of swollen joints, but yeah, I wrote it as tender because and we could argue. I'm a big fan of tender joints. Because it's the same between me, my nurse practitioner, the primary care, and the resident. When it comes to swelling, only you have the magical fingers of an ultrasound machine that can detect, that subtle synovitis. So
Well, and this is
So tender joint is
preclinical
the first
too.
thing to respond to placebo in clinical trials, but we won't go there.
And this is preclinical, so people
Right.
with swollen joints wouldn't be.
True.
My guess is if they're tender in other hands and you got your hands on them, you'd find swollen. So
I'm always surprised at that, even amongst rheumatologists who are skilled. How do you manage preclinical RA in your practice? Half of the people say symptom management, a little bit more in the United States. 25% say I'm going to observe and retest. And really, in the United States, it's like 14% say I'm going to treat with some drug. And in the rest of the world, it's like 24% I'm going to treat with some drug. Right now, most people are really quite conservative in something that they think is preclinical RA, which means, as Glenn said, they don't yet have a swollen joint or swollen joints,
Fair
and they
enough.
don't meet criteria.
The one situation that's I kind of mentioned it earlier in this preclinical RA, but the patient who comes in, which I see not infrequently, where they give a really good history of having what sounds like this palindromic arthritis, but you see them and they're doing fine, and you can't, you're supposed to document synovitis to make a diagnosis, but you're really relying on the history that someone gives you. And in that situation, I do treat some of those people, particularly if their CCP is positive. So I don't know what you guys think about that, because that's actually something I see not infrequently.
Well, the CCP is sort of like, well, there's so many things that are important. family history, number of swollen joints. If you have, and if you don't have some number of swollen joints, even number of joints has some predictive value, but CRP, ultrasound, MR evidence of inflammation, smoker status, they start adding on. But to me, it is the CCP, and that actually is, well, before we get into the CCP, I asked this question: what do you need to better manage preclinical RA? Half the respondents said, I need information on how to treat aggressively and when to treat aggressively. That's 50%. 13%, I need to know when to just treat symptomatically. And then only 15% are looking for criteria, and 20% are looking for some better testing or rules on testing. I think that this says that as much as we talk a lot about, and we've seen a lot of preclinical RA studies, there's a lot unknown about what's important, how to proceed, next steps. And I think that leads to the conservatism we've seen in these survey results. What do you think?
Well,
Yeah, I think, again, there's a variation. If the arthralgias are in the MTPs, MCPs, PIPs, and they have seropositive, I'd probably go so far as to ultrasound them and look for erosions, because there's a good probability they'll have one. But, if it's very vague arthralgias, or perhaps even fatigue and malaise and some achiness, and but still a high positive CCP, the odds that they're going to develop RA in 3 years is still around 30%. So, there is a watch and wait depending on the patient.
right,
Yeah.
I mean, I agree, this is all because like you said, it's 30% will go on to progress, which means if I were to just start throwing drugs at everybody at that first visit, I'm treating 70% of people who don't have RA. So I don't want to do that. This is, what you described, they have swollen joint, they have erosions on ultrasound, they have MRI findings. Well, again, that's where we started, you and I both. That's not preclinical RA. That's
But it still
aggressive
comes
rheumatoid
under,
arthritis.
if you never did those tests, you wouldn't know that. And,
Right.
we all go by our gut sometimes in this.
Right, so you have to know where to draw, and the other problem is, so far, the studies have not been impressive. I mean, the abatacept studies are the only ones that have something to me. The rituximab studies didn't show anything, and the hydroxychloroquine studies didn't show anything.
The ABBA, it looked like you needed to give it again, but it did
Right.
appear to do something.
But I'm saying it's the only one that showed any kind of positivity in my book.
Yeah, and the methotrexate
negative.
too, yeah. It didn't show this. As soon as you stop it, it's good while they're taking it, but as soon as it doesn't delay, sort of prevent the progression into
means
RA.
they're treating the disease, but that study was done before the criteria. That was the prompt study.
Yes, yeah.
When you looked at the criteria for that study, they were almost the ACR criteria.
So one of the docs in the audience asked the question about those stop RA patients who didn't get RA after 3 years of follow-up. This is sort of like you're seeing preclinical RA and you do treat them, you don't treat them. What's your rules on return to clinic? Vivian, what do you do?
Depending on the picture and depending on if there is any evidence of evolution, it's like come back in 3 months, 6 months, 1 year, depends. Here's my phone number, please call. And I tell them what to look for. But if there's nothing to indicate that they're going to convert anytime really soon, I will do the watch and wait as well.
Yeah, to me, the smoking gun is the rheumatoid factor. Here's a study that this is well, actually, it's not this one, the next one. This is a cross-sectional study about referral. And these are people in the Vermont medical school system, 1,000 patients referred, I think in a 2-month period. 85% of these were from primary care doctors. They evaluated only 700, so it's only 70% got a consult. Slightly bit of a problem there. And only 26% of those had inflammatory arthritis, half had OA, 21% had fibromyalgia. On the right, you see the answer to the question, maybe Dr. Kerr's question, arthralgias being referred. They don't really talk about the labs, although a lot of people had labs, that 18% actually evolved into having RA. They showed in the consults that they were woeful as far as documentation of a joint exam or key things like the duration of arthralgias or morning stiffness. The time to the actual rheumatology appointment was a median of 9 months. But even despite
9 weeks.
9 weeks, sorry, even
That's
though
fantastic.
that's actually not bad. You're right. But despite some of these things, they were very good at ordering ANAs in half the cases, rheumatoid factor in 38%, CCP and B27 in far less patients. But is this a good story for, are we doing good with referrals here in the United States? I don't think we are.
I think there's a lot of,
Yeah.
I was
Go
just going
ahead,
to say gaming, I don't want to say gaming the system, but when family docs will learn what to write on a referral to try to get people seen more quickly, I think in some cases. And this is why, so in where I practice, we have a centralized referral. So all the referrals come into one center and then get distributed. So they have a huge volume of referrals coming in a day. And that's really why they rely, on the lab tests. And it's not so much that, people who are seronegative won't be seen. It's just to avoid missing the people who have real disease and putting them on a wait list, if they have a vague history and really high rheumatoid factor CCP.
Right. I guess the theory there is better to catch some with obvious disease and miss a bunch than miss a whole bunch, period.
Well, and it's interesting. I was just thinking, Jack, when you were talking about the AI and sort of how that will impact this, and I could see that more testing, that could lead to more tests because the algorithms would have an objective thing, an X-ray that they could read or a test that could. So it'll be it's interesting whether that'll, if that happens, that whether there'll be more testing to kind of feed into these algorithms.
Yeah, that's one of the problems with AI and making these decisions and making recommendations is they are going to be very algorithm driven. And you could see that more testing and maybe useless testing emanates from some of that.
Yeah.
And it's also done, you have to remember, the programming is done by a human.
Mm-hmm.
Maybe.
Oh, yeah.
If someone comes in with fibromyalgia and their CCP is over 250 and their RF is 100 and whatever, I'm going to take that patient very seriously because there's fibromyalgic presentations. There's also polymyalgic presentation. Nothing, if it were really simple, we wouldn't need to be rheumatologists, but it's not.
So you're driven by the CCP. Here's a study from Paul Emery's group. They have an early arthritis clinic, obviously, 780 referred patients, only 3% were CCP positive, but 45% of those progressed to RA. And on top right, you can see that line that's not dropping off are people who are no symptoms and low or no titer. And the ones that are dropping off the fastest are the people who have hands and feet symptoms and have high titers. The predictors of developing inflammatory arthritis, 9-fold higher if you have high CCP, 2 to 4-fold higher with hand and foot pain. And then of the CCP negative people, only 0.93% progress. So in their algorithm, you could start, and then if you do a CCP, if it's high titer, you sort of get an expedited evaluation and referral. If it's a low titer, then you get a lot of questions and routine referral, and that seems to make some sense. If you're negative, not much is going to happen.
I don't know how soon this is, but when I started doing early RA, which was in like 2001 or something, I went to see that clinic. I went to hang out there and see what happened. And there was a lot of OA, like generalized OA, because that's common, but it wasn't a whole lot more common. The trick they did was the MCP and the MTP squeeze test. It was a very quick way of deciding who was going to get a longer assessment.
Yeah. Two really good points from people who really know. John Tesser says he relies on patients taking photos of swollen joints in between visits.
Yeah.
You know, I must say that 8 out of every 10, maybe 7 out of every 10 photo a patient shows me of a swollen joint is like okay, if you say it's swollen, but it's really not in my view. But I give it full respect that it deserves. I think that is a valuable way of picking up early disease. And another comment is that preclinical RA is someone with serologies and no symptoms and maybe back pain. So this is something that Kevin Dean has also weighed in on. So,
Yeah.
you know, I think preclinical RA is only preclinical RA if you have really high titer rheumatoid factor and a first degree relative. If you have no symptoms, you know, it's just a worrisome patient with a 40 to 60% chance of having RA. I'm saying high titer or multiple autoantibodies. So, you know, if you have any CCP, yeah, 30% is the right number, but that does ratchet up. And, you know, you're looking for a reason to worry. So seeing them is the best thing you can do. Do you think? Go ahead.
To me, this really argues for more CCP testing at the level of the GP, because it's the patients, you know, if you cost this out on a population, if you miss one person, you know, if you miss a small number of people who actually have RA, and I know I still see people who, if they had had a CCP done 2 years ago when they had symptoms, they probably would have got referred to rheumatology. So
Yeah.
There are parts of the world where you can order a rheumatoid factor or a CCP.
yeah.
You can't get both. And there's, to me, I mean, we're talking about a disease that will cost a certain number, you know, to the health system, millions of dollars. And people are quibbling with arthralgias and maybe small joint arthralgias affecting, you know, doing these tests.
And you can't walk into a cardiologist's office without getting an ECG. But we're going to worry about a $40 blood test.
Lipids.
Yeah, exactly.
Well, do you think it would be better if there was point of care testing? If there was a finger stick and a home test that we'd be more likely to see these patients?
Absolutely.
I think so. Yeah.
You know, are you waking? I can see the commercial. Are you waking up stiff in the morning? Do you have pain in your hands? Well, try the new Room Now. And you know, you stick your finger in if it's
Okay,
possible.
we're all on this patent, all right?
Yeah, okay. Yeah. Well, I mean, I do think that there would be a big use for it in lots of places, in primary care and doc in the boxes, even in your office and whatnot. So it should be done. I don't know why it hasn't already been done. So all right.
Didn't you go to the jail for that kind of stuff?
No, absolutely not. I mean, there's
No.
testing for HIV and COVID and now A1C and you name it. I mean, it's all out there for better. Well, let me ask you this. Do you think that we would do better if there was a large scale effort to do telehealth with early presenting symptoms?
I'm not a big telehealth fan.
Okay.
I'm sorry. I may be in the minority here, but I did not find it. Yeah, for me, telehealth was great if the patient was doing great, or if the patient was doing horribly. But I couldn't assess anyone in between.
You know, it took time because it takes time because you have to explain to them exactly what to do to convince you one way or the other. And, you know, that may be where our rapids, our RAFQs, our promise measures, or, you know, something is going to tell us.
Yeah, I am a big telehealth fan. I do think it's a great screening tool. It's a great tool for people who are established stable disease, and it's a great way to deliver cost-effective care. I think you can do effective joint assessments. Yeah, things that are clearly swollen, you can see it from, you know, across the supermarket. Why shouldn't I be able to do it, on a Zoom call? But there
Yeah,
are
and the
people where,
patients, they just want to call and get some questions answered, making them travel some distance or some amount of traffic, it's a problem.
yeah, telehealth does have lots of problems, including setting expectations with patients about what this visit is. This is this is a regular visit. This is not me calling you for a social, how you doing, and you're going to be in my office next week wanting to get examined. No, I just did that last week. All kinds of little things like that. I'd like to end with each of you maybe imparting some wisdom on the audience on, what would be your greatest advice about doing better at early RA. My big pitch, and I kind of said this in the beginning, is I think if you really want to see RA, I think you should get a mailing list from the hospital system that you're associated with. Send everybody a note saying, I want to see your early RA patients. Positive squeeze test, do CCP and rheumatoid factor. I'll see them over lunch. I'll stay after work. Send me those patients. And yeah, you might get a whole bunch of, fibromyalgia. You'll get an occasional Churg-Strauss syndrome or something, but you will get more early RA than you've ever had before.
It is true.
Yeah. Marty,
Mine-
what would be good?
Yeah, go ahead,
What's your
Marty.
advice?
Who's-
Viv?
Mine,
Yeah.
mine is be careful what you're messaging the patient. When you are saying, oh, I don't know if I'm going to give you methotrexate, let's try a little Plaquenil. I mean, what are you telling that patient about methotrexate? I saw someone like that last week, and they're both were hesitant, and the patient's hesitancy drove bad decisions. So I think telling the patient about the disease is as important as discussing the pros and cons of the therapy.
Yeah. Marty, what's your message?
I mean, I always talked about the side effects of disease as
Yeah.
well as the side effects.
Yeah,
of the
exactly.
medicine. But getting to your question of how do we get people in earlier? Because that's what we're trying, I don't have a good answer, because even when you have these questionnaires, majority of rheumatology practices are absolutely booked out 3+. If you can get a rheumatologist, if you can call someone and say, I have a sick person and they need to see you, if you can get them in under 2 months, you're a magician. So it's, I think the solution is we need more rheumatologists. Right now we're one of the hardest, if not the hardest fellowship to get into. And it's not as if we're not getting applicants. So it seems to me if we have applicants and it's difficult, you get more spots, we get more rheumatologists, we get people in sooner. I mean,
Yeah, it would cost more money to the system, but honestly, we need to have less clicking on Epic.
Yeah.
It takes time.
Glenn, what's your advice?
Maybe just on the sort of a bunch of these treatment decisions we talked about is setting the sort of long-term expectations of what treatment is going to look like when you're first starting treatment, with the acknowledgement that, if you're starting triple therapy, if you're starting sub-Q methotrexate, if you're deciding to treat preclinical RA, that, this isn't for life. And the goal is to get people better as quickly as possible. And then you can always talk about reducing medications and that you'll work with patients on that. I think hearing that message that, what they decide now doesn't have to be what they're going to be on for their life. And every patient wants to be on the least amount of medication while controlling their disease. So that's one thing I found helpful, is just talking with patients about that.
I often, if there's hesitancy and a lot of indecision, I use the phrase, it's a date, not a marriage. And it's exactly what you're speaking to Glenn.
and I would just put in another plug for measuring disease activity.
Absolutely.
Because if you're measuring, if you have, and you tell the patient why you're measuring and how you're measuring, they come in, and if they are doing better, they're doing better. And if their numbers are bad, you can tell them, well, I'm not telling you you're doing bad. You're telling me you're doing bad based on what you're telling me what I'm finding. And I think it makes the discussion a lot easier to get people to take medications when they understand why they have active disease and why it's important.
All right, folks, I want to thank our panelists for a really insightful discussion. I think this is all very practical, very useful. I think we've highlighted some of the challenges yet ahead of us. I want to remind the audience to follow all the content on RA this month. We've got amazing blogs and videos that are being posted every day. Watch for those. Next week, Tuesday Night Rheumatology is all about methotrexate, where Mike Weinblatt and Joel Kremer are going to host a panel where they're going to take apart what we're doing right and what we're doing wrong in methotrexate. That's next Tuesday night, 7 p.m. Eastern. Thanks, everyone. Have a good night.
Thanks all.
Thank you.
Bye, everyone.